Welcome everyone to the Consciousness and Reality Colloquium. Our participants today are from primarily Caltech, MIT, Stanford, and IMIX, and I'm Kunal Mule, an astrophysicist, and the co-founder of IMIX, which is the Institute for Mind, Intelligence, and Consciousness Studies. This colloquium series seeks to inspire interdisciplinary investigations on wide-ranging topics, important topics like mind, intelligence, cognition, consciousness, and the nature of reality. So just some quick points on logistics before we introduce our colloquium speaker today. Select questions from the Q&A box will be taken after the talk. So I encourage all of you to please submit your questions through that Q&A button that you can see at the bottom of your Zoom window. And we will be making this more interactive and fun. Of course, Stephen's talk is going to be hugely interesting, but just to make this a teeny bit more interactive and fun, you can click on that poll button below to answer two simple binary choice questions. And I'm going to start the poll right now. Here you go, launch. And I believe all of you should be able to see this on your screen. So two questions, binary choice. The first one is the most important direction in brain research is, according to you. A, is it understanding mind and consciousness, or B, treating brain and mind disorders? So we see that our participants have started answering this already. The second question is the best outcome of research on meditation, hypnosis, and near-death experience is, according to you, A, whether consciousness can go beyond the biological body and experience alternate realities, or B, understand mind-brain connection. So keep clicking away on those two questions at the poll there. And I will announce the results of this poll at the end of the talk. So I now request our co-host, Martin Fleming, to please introduce our speaker, Dr. Stephen Laureys.
Thank you very much, Kunal. So, hi, I'm Martin Fleming. I'm director of the Science Philosophy Initiative based in the UK. And it's a pleasure to welcome and introduce Stephen Laureys, who I was very fortunate to hear at the Science of Consciousness conference held in Tucson, Arizona, just over a month ago, where he did a great presentation, but the star of the show was his young son, who really stole the audience. Stephen is a clinical professor, he's a research director, and the founder of Giga Consciousness and the Coma Science Group at the University of Liège. He also holds the Canada Excellence Research Chair in Neuroplasticity at the Servo Brain Research Center. He's an invited professor at Harvard Medical School and fellow of the European Academy of Neurology. His research encompasses the neurology of consciousness, where he explores meditation, sleep, coma, near-death experiences, psychedelics, hypnosis, and dreamlike states. Stephen is also the author of several books, including The Neurology of Consciousness and the international bestseller, The No-Nonsense Meditation Book. His work has featured extensively in media such as Time Magazine, BBC, and National Geographic, and he's been a speaker on many TEDx talks. Stephen, it's fantastic to have you with us today. I loved your plenary talk in Tucson, and I'm eager to hear you once again. The stage is now yours.
Thank you so much for having me. It's a pleasure to share today my passion, and that is understanding our thoughts, perceptions, emotions. I think the study of consciousness is extremely challenging and definitely needs expertise from many different angles. As you said, I'm a clinical neurologist and also a neuroscientist, and very happy to translate our understanding of the neural correlates of consciousness into clinical practice. And we do that through the use of all possible machines, neuroimaging, in different conditions. As you can see, first through the pathological modifications of consciousness. So I founded the Coma Science Group. A huge challenge there is to help clinicians to reduce the uncertainty about the diagnosis. Is there consciousness? If so, what kind of, and is there a chance of recovery, and can we do anything to improve the outcome? And then there's pharmacological modifications, general anesthesia, but also psychedelics, very interesting emergent field. And of course, the physiological modifications we can all appreciate when we fall asleep, when we dream, but also through the study of hypnosis that we use for a couple of decades now in the University Hospital in Liège, and meditative states. So our big challenge as clinicians working in intensive care, emergency department, and neuro rehab is trying to say meaningful things about the level and the content of consciousness of people who suffered severe traumatic brain injury or hemorrhage or survive a cardiac arrest, but cannot communicate their possible thoughts, perceptions, and emotions. And so we do that, as you can see, by measuring their brain activity and the structure using all possible technologies. And that actually brings me back to how I started neuroscience while still a medical student in the 80s, early 90s. I was studying pain, neuropathic pain in rats as this little fellow, and studying changes in their brain activity, actually doing neurodialysis in the thalamus. And it was quite frustrating, really, because I was inflicting pain by definition on these animals, but of course they couldn't tell me what they really experienced. And that is actually still the challenge today. It is the challenge of possible consciousness in babies or even before birth. And actually I gave a TEDx with my youngest son, Martin, you referred to him, at the Tucson meeting. He was then still, really a baby. And well, again, we made the historical error to underestimate the capacity of consciousness in newborns. When I was in university, medical school, we were told that in the 80s, they did not necessarily feel pain, and they were having interventions that were potentially painful without analgesics. And now we know, luckily, that is not true when we give appropriate treatment. It is also true at the end of life. When does consciousness end in severely demented patients? We tend to call vegetative when they can no longer interact. And again, their studies show that there's more going on, definitely what concerns their emotions than we tended to believe. And I think it's true also for the animal world, the non-human animals. And I'm very happy to be a co-signer of the Cambridge Declaration on Consciousness, to say that from a neurobiological point of view, it doesn't make sense that we would be the only one suddenly having this consciousness. And of course, that has major bioethical consequences. So how do we measure consciousness when we have no explanatory theory? It's one of science's biggest mysteries. And the answer to what consciousness is will be different if you ask a philosopher, if you ask a person working with AI and computer possible consciousness, or someone doing animal research, or an anesthesiologist. So at the bedside, as a neurologist, we will reduce the complexity of what we call consciousness into two major dimensions. The first is the level of consciousness, wakefulness. And that's quite straightforward. We measure that at the bedside by looking at eye opening. So if you start falling asleep, you will close your eyes at one point, lose the awareness of what's happening around you. That's what we know from, hopefully, every night, good night's sleep. And we also know that there can be something very notoriously difficult to appreciate, which is dreaming in REM sleep, rapid eye movement sleep, where for the observer, you look unconscious and asleep, and yet you have these very vivid real experiences. And that is even more so for lucid dreaming, where in REM sleep, you become aware that you're dreaming and you can decide your actions while living these surrealistic scenarios, which I think is, again, a very, very interesting dissociation. And then there's, of course, coma patients after severe brain damage, where by definition, patients can no longer open the eyes. Even when we stimulate them with auditory or noxious stimulation, their level of consciousness is very low, and hence their content of consciousness or awareness of the environment and awareness of self. That's also true for pharmacological coma or general anesthesia. And then, since the new technologies invented in the 50s, the artificial respirator and a new field in medicine called intensive care medicine, we had these people who survived coma, awakened, opened the eyes, yet only showed reflex motor behavior. And that was called persistent vegetative state in the 70s. I do not like that name. We're not going to compare human beings to vegetables. And so with the European Task Force, we put a lot of effort in replacing persistent vegetative state by the more neutral descriptive term of unresponsive wakefulness, because that's what we see. Patients seem awake, eyes wide open, and yet do not respond to simple commands. And that is the clinical way to appreciate awareness, which is actually the same as my colleagues in ancient Egypt. So it's asking a person to do something, like squeeze my hand. If you do that, fine. As a neurologist, as a medical doctor, that's proof that you heard, understood, and did what I ask, and hence are conscious. But if you do not, I have not necessarily proven that you are unconscious. There can be very, very many causes that you would fail the test. Maybe you're deaf. I would write it down. Maybe you're paralyzed, of course, after a severe accident. There's damage to the spinal cord, to the nerves, and your brain is saying, move the hand, but it's no longer connected to the muscles. Or maybe you're aphasic. You don't understand the question. It's very difficult for us. Doesn't, of course, mean that you're completely unaware. Or maybe you just don't feel like answering, which is what reminds me of a lady I saw after examining her repeatedly in intensive care in coma, and later unresponsive wakefulness. And she told me, well, you know, Dr. Laureys, I remember you asking me, squeeze my hand, do this, do that, but I didn't see any reason why. That's a condition called akinetic mutism. Of course, then again, we're in trouble. There's other conditions in neurology, such as sleepwalking, or in epilepsy, complex partial seizures, absence seizures, where people would fail the awareness test. They would not answer simple commands, yet do show some automatic motor behavior. And then there's this very challenging condition called minimally conscious state, actually only defined not in years 2000. And we subcategorize that minimally conscious state, MCS, into MCS minus, and these are patients who show non-reflex behavior, such as smiling when their mother or another important person for them is in the room, but not when it's other people. So we can't say it's a reflex. Or following with their eyes, or orientation to pain, but that's all you have. The next step is MCS plus, and these people do answer simple commands in a reproducible way, but you can't use that movement to establish a functional communication. And actually, maybe we should call them minimally responsive, because that's really what we do. We make inferences based on motor activity, with regard to the possibility of consciousness and cognition. And we can get it wrong. The most extreme example is locked-in syndrome, where people after coma awaken, are fully conscious of everything that happens around them, external awareness, internal awareness, but they're completely paralyzed. They can't move their arms or legs, they can't speak, except for small movements of the eye. And that's the only way for you to establish a communication and obtain a yes-no response to your question. So locked in, fully conscious, paralyzed body. And so we see that there's this relationship between the level of consciousness, wakefulness. When it goes down, so does the content of consciousness or awareness, and that's typically happening in sleep. Of course, that's reversible, as is pharmacological coma. And in pathological coma, we would see this recovery first of the arousal system in the brainstem that makes you open the eyes, waken up, and then next, the recovery of the awareness networks that are higher in the cortical center. So when we started our research in the 90s, it was not clear whether consciousness could truly be located to some parts of the brain or whether it was just dependent on overall brain activity. So we used what was, and actually still is, one of the best markers of synaptic activity, and that is FDG-PET, fluorodeoxyglucose labeled positron emission tomography. Your brain uses a lot of energy. We can measure that by injecting marked sugar, and this is what you get in a healthy, awake and aware volunteer. So it's billions of neurons using a lot of energy, and these are artificial colors. And of course, if we start with the extreme in brain death, the neurological definition of death, we see the empty skull sign. So when you inject your metabolic tracer, you just see activity in the skin surrounding the skull, but nothing inside the billions of neurons. So brain death truly is the definition of death based on the absence of overall brain activity, as we can document it with these metabolic PET imaging tests. When you go to deep sleep, you see a massive global reduction. When you're dreaming in REM sleep, we see paradoxically a return to overall brain activity quite similar to what we see in waking. So notorious exception where from the outside it looks you're unconscious, and yet you have these very vivid mental activities. When you are giving anesthetics, you again, this is an example using propofol, have a massive global reduction. When you stop the drug, consciousness returns, and so does overall brain activity. So here it seems that yes, indeed, there seems to be a threshold. If overall brain activity goes down, you're unconscious. If it comes back, consciousness comes back. I think one of the major contributions of the research of patients in coma and our team is that that is not actually the case. And we understood that from pathological coma and vegetative unresponsive wakefulness patients, where you see again, when we studied them in the 90s, there was this massive global reduction. But when we looked at those people who recovered, they did not recover activity in the all 100% of cortical metabolic levels. Rather, the global activity increased a little bit, but what really mattered was the regional increase in these awareness networks. And we've been exploiting those data obtained by initially glucose PET, later functional MRI, high density EEG. So by all possible modalities, feeding this now to AI and having classifiers tell us, is the patient conscious or not? And actually, it's a wrong question, because consciousness is not all or nothing. It's not binary. So it's not even 50 shades of gray. We should maybe compare it to all the colors of the rainbow. It's really multidimensional. And we see that there's this non-linear progression in brain activity and cortical and subcortical connectivity when we compare those different entities we just described. But of course, those classifiers and the big data crunching is very, very helpful for physicians to reduce the diagnostic uncertainty. And that is especially true for the measure by whatever method you use of the functional integrity in the awareness networks. And where are they? Well, you see them here. So what really seems to be important for you to be aware of your environment and yourself is that widespread frontotemporal parietal network, both convexities and midline, mesiofrontal, anterior cingulate, and then posterior cingulate precuneus, that seems to be dysfunctional in both coma, but more importantly, in people who are awake yet unaware, vegetative unresponsive wakefulness. We see similar images in complex partial seizure. This is an image obtained by SPECT imaging, absence seizures, an image obtained with fMRI, and then sleepwalking, study done by Claudio Bassetti. Very difficult to inject the tracer when people in slow wave sleep suddenly start moving around, and you see again this breakdown of this high-level frontoparietal network, where now, of course, we also have the tools to look at the interaction between these different parts of the brain. And we've been using many paradigms. This is an older paper with Melanie Bowley at the time in Liège, now a professor in medicine, where we used auditory stimulation, high density EEG in intensive care, as you see on the picture. And then we look at the interaction using dynamic causal modeling of the higher order awareness network, number 3, onto the auditory sensory areas, number 1 primary, to the secondary auditory areas. And it seems to be the case that for you to be conscious of the auditory stimulus, you need that top-down feedback connection. And that was not observed in people who are comatose, anesthetized, or in unresponsive wakefulness. And that can be calculated at the single subject level and is, of course, useful in a clinical setting. So we've been using all of those possible approaches and methodologies over the past, nearly 30 years now. And it's increasingly clear that there are patients where at the bedside we think, well, there's nothing there, there's only reflex activity, there unresponsive wakefulness. Yet when we do the PET imaging or high density EEG connectivity studies, we see that surprisingly there's more going on inside the brain, hence inside the mind of these patients. So typically we would see the massive global reduction in unresponsive wakefulness. You see here on the top left, very different from healthy controls where there's a red high active neuronal activity. Minimally conscious state is kind of minimal, intermediate. And then you have those people where clinically you think they're unresponsive, but their brain imaging show that there's more going on. We call them minimally conscious state star or cognitive motor dissociation. So more brain activity as identified on neuroimaging, and also with the high density connectivity. You see there, we made the cover of Annals of Neurology a couple of years ago. You see both in the alpha band and delta band, clear difference between unconscious, unresponsive, healthy volunteers or locked in patients, intermediate MCS, and then you have those where clinically there's nothing, and yet the neuroimaging shows that there's way more activity. And how many of the patients is hard to say, but it's an important minority that we could, using fMRI, even give a possibility to express themselves. So the first paper we did with Adrian Owen using the so-called imagine playing tennis paradigm is basically doing the same we do at the bedside. Squeeze my hand. If you do, I know you're conscious. But now we would do this in the fMRI machine. So we had this little trick to ask them, imagine playing tennis, because it activates a large motor network, and then there were many other questions. It turned out that imagine to walk around in your house was a powerful one. We could decode looking at parahippocampal areas. And then we had a test where patients inside the fMRI, where we observed there was more activity going on, as I just described, could be challenged. And we explained them, well, if you are, if you want to say yes, imagine playing tennis. If you want to say no, imagine walking around in your house. And you see the first patient that was sent to our center in Liège with a very important traumatic brain injury. You can see on the structural MRI, there's a lot of hydrocephalus, meaning that there's more liquid in the brain taking in the place of that cortical atrophy. There's basically very few brain left. And again, this patient was sent to us with the label vegetative. We saw there's more going on. We put him in the fMRI and then ask him a question. He's playing, imagine playing tennis. So decoded as a yes. Question 2, doing the spatial navigation, saying no. Question 3, saying no. Question 4, saying yes. 5, and then 6, no answer, probably exhausted. So this was the first time we could show proof of principle that some of these patients not only had the capacity for conscious awareness, but also using motor independent communication channels as offered with fMRI could answer simple questions. And these were very simple questions like, is your name Alexander? Is your father's name Thomas? So we knew the answer and then we could decode it. Of course, this is very difficult to do in our center. Actually, this fails in most of the patients because there's movement artifacts. So we need simpler solutions, and this is EEG-based, so-called brain-computer interfaces. We work with the first and still only commercially available BCI from GTEC, the Mind Beagle. We use that in intensive care. You see there a patient with severe traumatic brain injury with the EEG cap. We ask him questions and when we decode the brain activity. So there's many ways to do this. We've published extensively. There's another paper with Damien Cruz where we asked, move your foot. Then we know Penfield, this is more midline, move your hand, it's more lateral. We can decode that and see in some of these patients whether this can be used as a communication channel. And then we see again, if we cross-validate this, that there's also more metabolic activity as captured by PET imaging, as you can see on the lower right. And this really matters. This is really making a difference for an increasing number of patients throughout the industrialized world, both in Europe, North America. And this is an early paper with Caroline Schnackers, at the time a PhD student, now a professor also in LA. And we had a young patient with a very extensive brainstem hemorrhage. You can see the MRI, but the problem was that when I examined her at the bedside, there wasn't a single sign of consciousness. So even if I opened the eyes manually expecting a locked-in syndrome and I asked her, look up, look down, look left, look right, there was no answer. And so we concluded to the diagnosis coma, and then we did this, one of the first studies, active event-related paradigm, presenting names, and we asked her count each and every time you hear your own name, and we had this increase in the P3, and that is the only thing we had to say, well, wait a moment, she is actually conscious, and we continued the care, and of course the respirator, and there was a discussion at the time, should we let her die or should we go on? And now she recovered and can control her wheelchair. For those interested, Caroline and I edited the volume Coma and Disorders of Consciousness, discussing of all the implications and the impact of the new technologies. So this is wonderful. To wrap it up, we have people in coma where when they open the eyes but only show reflex movements, this is now called unresponsive wakefulness. Historically, vegetative state. When we have non-reflex behaviors such as appropriate smiling or crying, so very often it would be emotional stimuli or localization to pain or visual pursuit, we call them MCS minus. Next step, reproducible command following MCS plus. If we look at the difference between those two entities, MCS minus and plus, we see that there's a functional neuroanatomy that differentiate these both categories with more left-sided brain damage, left dominant hemisphere encompassing the language network. And so this is a big problem because of course, if you fail to understand our questions, it doesn't mean that you're completely unaware and can have, of course, still emotions, including pain. So we should adapt our tests. And even the fancy Imagine Playing Tennis test is suffering from this because people need to understand what we ask them to do. And that is why we put a lot of effort in so-called resting state paradigm. So we just put the patient in the machine, hit the record button, and then we see those spontaneous activities. We have different ways to analyze that using principal component analysis or hypothesis-driven seed voxel analysis, identifying here default mode activity. And we can see a breakdown of that default mode activity when we looked at healthy volunteers or locked in versus minimally conscious versus unresponsive and comatose. So that again is very helpful to help clinicians making very important decisions. It also turns that a very important area that separates MCS from unresponsive is that highly connected hub precuneus posterior cingulate cortex, as you can see. So we can be all excited. We have these networks we can visualize, and then we think we see consciousness. And this is another example of a patient with a lesion in the brainstem. You see the white arrow pointing to that black, which is ischemia from a basilar artery thrombosis. Very difficult in the acute setting. We showed that actually the majority of these patients, we fail to identify them, and it's the families because they have this unique relationship, and we should actually more integrate them in our assessment. Yet, of course, sometimes the images lie. We think we visualize consciousness, and of course we don't. These are very indirect measures. We can have false positives. There can be artifacts from heart activity or breathing movement. So this is a big challenge. Also, the other way, sometimes we know that the patient should be conscious, and yet we fail to visualize any activity. We can't pick it up with the test. So there's basically no gold standard. It's very different if I would look at a brain tumor. Is this a cancer? Well, even if the patient die, I can take a biopsy, do the histology, and post-mortem say, yes, he had this or that disease. We can't do that. We can't look for consciousness when people are dead. And we need to do the best we can by combining the different machines and techniques, but also by combining the different impaired states of consciousness, looking at these tests in anesthesia and other conditions, which is exactly what we do. And then with multicentric collaboration, this is one of the papers using resting state and the classifiers, helping again the big data crunching, using in this case support vector machines to help us categorize this patient is unconscious, unresponsive, or minimally conscious. And that has also, as we're showing, having prognostic value. Another, I think, very interesting approach is to stimulate the brain with TMS and simultaneously record the EEG. This is actually developed by Marcello Massimini in Milano. He published that there is a breakdown of the complexity in sleep, and then we did this in anesthesia. We did this in patients in our center in Liège, and this is now used in many centers worldwide and proposed the perturbational complexity index, also together with Giulio Tononi, and fitting in his theory that for you to be conscious, the information needs to be integrated. And so we can test that by perturbing the brain with a TMS and then looking at the electrical echo and the complexity of that, and we can calculate that in a number of ways, tells us something about the capacity of this person to have consciousness. And we looked at many, many healthy volunteers, locked-in syndrome patients, minimally conscious state patients, compare it with sleep, anesthesia, and then you see the subject with unresponsive wakefulness that are below this threshold of 0.3 on this quite ambiguous idea that we can reduce consciousness to one dimension using the PCI, perturbational complexity index. We actually also did this not only in anesthesia using different, you see there, propofol, xenon, ketamine, but also in meditation. And I would, at the end of the talk, like to talk a little bit about our project in that field. You see, probably you'd want to recognize him, but this is Mathieu Ricard, the Buddhist monk, translator of the Dalai Lama. He actually holds a PhD from Institut Pasteur and then, you know, became famous postdoc and very, very appreciated scholar in Buddhism. And he came as a guinea pig and was very interesting for us to see that this was the first time that someone could modify our measures by these meditative practices using EEG TMS, and that was both increase when he was doing specific meditation practices or decrease, and we'll continue again that line, and that's the work of Olivier Gossery. Okay, pharmacological coma, general anesthesia, many opportunities there using a number of drugs, where basically, to wrap it up, you see again this breakdown of connectivity in that widespread frontoparietal global workspace as initially proposed by Bernard Bars. And importantly, it's not happening in your sensory areas. So we see, for example, when you look at awake and anesthesia, in the visual network, you see it on the slide, and then below on the auditory networks, well, even in this case, in propofol anesthesia, you still see functional connectivity there. So these networks are necessary for you to see and to hear, but not sufficient. I would call them kind of slave systems. Where it's really happening for you to make sense of that sensory stimulation is in that higher order frontoparietal network. And we then propose that this widespread global neuronal workspace can be subcategorized in two aspects of awareness. One is external or sensory awareness, everything you see and hear right now, and that's in red, prefrontal, temporoparietal, both hemispheres. And then there's basically the rest, internal awareness, your stimulus independent thoughts. You close your eyes now, you can have visual images, you can anticipate what's going to happen. You can, of course, think about what happened before autobiographic memory, so overlapping with the default mode. And we did a number of studies. This is one fMRI study in healthy volunteers who put them in the machine and they have nothing to do. What happens? Of course, you think. You can't help it. Your brain is thinking. And then we had them stimulated with a little beep, and then they communicated with switch what they were having as experience. Was it more sensory, external awareness, or was it more internal? I'm thinking about, you know, what I need to do later in the day and so forth. And you see that the scores of internal awareness correlate indeed in red with that external awareness network, and in blue, internal awareness with the midline core. And we see that these networks, as is of course now being repeated extensively, anti-correlate. So it's either one or the other, and they fluctuate with a 0.05 hertz frequency. In other words, every 20 seconds on average, you go from more sensory to more internal. And also during these webinars, you're not listening to me the whole 45 minutes. you're thinking about many, many other things. And then again, we can use that and decode the activity measured in non-communicative patients. And that spontaneous fluctuation of internal, external awareness network actually influences how we perceive the world. And again, an early study from Melanie Bowley showed that if we monitor the activity in the external and the internal awareness network in the fMRI, and then we hit with a laser sensory stimulation, and we make it so that this is like threshold intensity, half of the stimuli, laser stimuli to the hand, the volunteers would say, I didn't feel anything. And the other half, they would say, yes, I felt it. And she could predict if your external awareness network is high, indeed, you would feel it. If you were more thinking about stuff and your internal awareness network was high, then you would not perceive it. So that has later also been confirmed in auditory modalities. So the impact of those spontaneous fluctuations on how we perceive both our internal and external realities. Self or internal awareness is more tricky to study. We used a lot the own name because it's attention grabbing. We know it from the cocktail party effect. If you hear your name at a party, it will grab your attention. And we use that in people who awaken from anesthesia, awaken from coma, and we see the correlation with this midline core, as we've shown repeatedly, proposing the own name in neuroimaging paradigms. So again, this is very useful because there's a big problem for clinicians when it comes to the diagnostic uncertainty. We've published that in about half of the patients. It's very hard because we have an inclusion bias. People we think are unresponsive, vegetative, have still residual brain activity and hence a working brain, a working mind. And we put a lot of effort in doing the best possible job we can clinically using behavioral scales to capture the level and the content of consciousness. So we use that not with the Glasgow Coma scale, because that's a coma scale. As when you open the eyes, it's not going to do the job. There's the Coma recovery scale developed by Joe Giazzino, and it's a wonderful scale, but takes a bit of time to learn and to do. So we invested in the seconds, and this is the approach of do less more, because these patients fluctuate so much. I could go into a room, come out and say, well, nothing there, come in an hour later, and I would have a response. So we've shown that we should see patients clinically at least 5 times before we make the diagnosis. And that is, of course, then better if you have a more simpler scale like the seconds. So that we miss patients clinically, we've repeatedly shown, this is a Lancet paper from a couple of years ago in 130 patients studied in our center, about 1/3, we can already change the diagnosis of the referring physician just by doing 5 repeated standardized bedside assessments. But then there's still 1/3 where, despite our best efforts, the PET or active fMRI paradigms, as studied in this study, do show surprising results. And it's those patients that actually afterwards have a higher chance of recovery. So it's important to show, first of all, they're conscious and we should adapt our care, but also they have a better prognosis. Now, what's the impact here in terms of the possible treatments? Well, we've actually early on observed that there's thalamocortical reconnections in patients who recover from the vegetative state, more specifically with the thalamic nuclei, the intralaminar thalamic nuclei that were then later stimulated by deep brain stimulation by the team of Nicholas Schiff in New York. You see here a MCS patient, traumatic brain injury, that recovered consciousness with bilateral thalamic stimulation. We've invested a lot in non-invasive stimulation, such as, for example, transcranial direct current stimulation. This is the work of Aurore Thibault. So 2 electrodes, 2 milliamperes for 20 minutes, and we've repeatedly shown in controlled clinical trials that a subset of patients do improve their level and content of consciousness. There's a number of other approaches that we have reviewed that truly permit to translate, of course, the things we discuss here to a better clinical care, also pharmacologically, with amantadine, with valpidem, sleeping pill that can very interestingly awaken some of the patients, but also vagal nerve stimulation, ultrasound stimulation, as is being done by Martin Monti in UCLA. And I mentioned the DBS and the TDCS. And of course, that matters because we're fighting from intensive care to neurorehab to have a better quality of life. What is it like to be minimally conscious? It's very, very difficult to answer that question. Actually, what we did is answering this question about what is it like to be in such a condition in locked-in syndrome patients. We had collaboration with the French Association for Locked-in. Many patients, we asked them the question, how are you? From a scale to -5, worst period in your life, to +5, best period. And this is what they coded using their eyes. Majority felt, well, good, +3, +4. So don't judge a book on its cover. There's a difference between a motor handicap and quality of life. Of course, there's also, you can see -5 and the discussion about euthanasia. In my country, Belgium, we can, do euthanasia, and the study identified that the quality of life correlated with access to technology, to the capacity to communicate in these patients. Very important also is the possibility for pain perception. I started the talk with the challenge to measure pain in animals. It actually is the same challenge in human beings with a severe brain injury, unable to communicate their possible feelings. So we apply noxious stimulation. It activates the whole pain matrix you see in healthy volunteers. And then in patients, sometimes only showing visual pursuit, unable definitely to tell you, I feel pain. The images tell us they do feel pain because they activate the whole pain matrix, brainstem, thalamus, primary sensory, secondary sensory, insula, and anterior cingulate cortical areas that we think correlate with the cognitive emotional aspect of pain. So we now systematically give painkillers to those chronic disorders of consciousness. So major ethical impact. And finally, I wanted very briefly to touch upon this very challenging reality of people surviving coma and then telling us later, well, doctor, I had this incredible experience. I actually felt very good. Many of them had an out-of-body experience, saw this light. So the so-called near-death experiences, and it's important that they are near death. They are not brain death, since we have the criteria since the 50s. No single patient with the clinical criteria of brain death and the correct diagnosis ever recovered consciousness. So to see, and this is again a older paper from Nature Reviews, is this massive global reduction in people with cardiac arrest, but it's not flatlining. There is still some cortical activity. And so our hypothesis is that probably you need less brain than we historically thought for you to have subjective experience, especially the pure raw emotion that NDE probably is. We now have thousands of these testimonies. If you know anyone, please send them to us. We're still looking for more. The majority are actually very positive. And then we showed that the etiology doesn't seem to impact. We can't say this is just explained by hypoxia or by some simple explanation, because we see similar subjective experiences in very different causes. And this is a kind of top 10 of what these people experience. Also, very interestingly, there seems to be a cultural component, because and we now collaborate with Russia, and there seems to be way more negative near-death experiences in the center we work at St. Petersburg. We also compare near-death experiences with the people taking psychedelics, and that permits us to say, well, what neurotransmitter seems to be the closest one, and we can have like DMT that is very similar, as is ketamine, to what we hear from the classical near-death experiences that occur after cardiac arrest. So to wrap it up, I think, really need all of you guys to think about what consciousness is, to come up with a truly explanatory theory. And while doing that, actually, the knowledge is already being transferred to clinical reality, improving the lives of people who suffer from coma. And it's clear now that some of these patients do have the capacity for neuroplasticity, for recovery. We invest a lot in robotics, as you can see here. This is a center that is in Antwerp and Amsterdam, and really making a difference in the lives of these people, especially combined with neuromodulation. So we simulate neuroplasticity with RTMS, with TDCS, and that coupled with robotics truly makes a difference. I just wanted to end with our more recent studies on these brilliant brains and the monks. I mentioned Mathieu Ricard. We had many others using all possible devices, and this is summarized in No Nonsense Meditation book, where it is clear that meditation and other interventions can change the structure and the function of the brain. So this is Mathieu and the DTI, structural connectivity. We, for example, see more transcallosal interhemispheric connections in people who do meditation. And you don't need to be a Buddhist monk, I'm definitely not, but mindfulness-based stress reduction 8-week programs already show changes in brain activity that we can capture. And I'm now speaking to you from China, where we study these Zen masters. So I have these portable devices. This is the NeuroSteer, just 3 electrodes. And then you can see the dynamics that change when these really experts are doing their meditative practices, and there's different forms, and you see the appreciation, the change in colors. For those interested, actually, I just finished another TEDx with my beautiful daughter. You see her here, and what happens in her brain when she did on stage the meditation. So to wrap it up, my passion is understanding consciousness, the power of the mind, both neuroplasticity in the damaged brain, important for me as a neurologist, but also learning from those different traditions. We mentioned Buddhist traditions, but there's many other possibilities. We've used medical hypnosis, and I would be happy to answer any of your questions in this regard, coupled also to virtual reality, a collaboration with a company in France called HypnoVR that offers, we have thousands of people who undergo surgery like thyroidectomy. We remove the thyroid gland. Of course, normally you're doing this in anesthesia. Here people are awake, but dissociated, disconnected, absorbed, and we see an increase in their internal awareness network, and it's a disconnection from the sensory awareness network that permit the surgeon to do his job. We also studied cognitive trance, the Mongolic traditions, and published. This is a collaboration with Corinne Sombrin. She wrote a wonderful book. I'm not sure it's translated in English, but it was made into a movie that exists in English, and that's called A Bigger World, summarizing how we can learn again from these traditions, in this case, shamanic effective music. And that, to me, is very important in these exciting days where we're using ChatGPT and AI, and the challenge to reconnect with our humanity, our emotional experiences that, of course, are inexistent in any form of AI. The most powerful computer, I am strongly convinced, has less consciousness, has no consciousness at all. There's more consciousness in a fruit fly than in the most powerful of our computers. And that is important to emphasize, that we need to invest in what makes us different from these machines. And one example is our study of artists, of musicians. And yes, ChatGPT can create music and make music. You see here the Toyota robot, but it is not feeling anything. With that, I am very happy to listen to your questions. So my challenge now is to translate all of that to better clinical care, and that's why I founded MindCare Foundation, and to really build a bridge between objective measures of brain activity using all possible devices and the neurophenomenology of that person laying there. And I'm very happy to see that's happening now. Definitely way more than when I was starting in the 90s. Thank you so much. Looking forward to your questions.
Thank you very much, Stephen, for that fascinating talk. There are questions trickling in, but before we go to the Q&A, I'm just going to show our audience the results of the poll. So I'm going to end the poll and share results. So there were two binary choice questions. The first one, what according to you is the most important direction in brain research? And about 90 participants answered this question. Actually, it's quite an even split, I must say. 54% said understanding mind and consciousness is the most important direction for brain research. And 46% said treating brain and mind disorders. The second question was, the best outcome of research on meditation, hypnosis, and near-death experiences is, according to you, A, whether consciousness can go beyond the biological body and experience alternate realities. 43% said that is what they think is the best outcome. And 57% said that the best outcome could be understanding mind-brain connection. So thank you very much for participating in this fun poll. I'm going to stop sharing now. And while again, the questions are trickling in, I'm going to take this opportunity to ask you a no-brainer question related to this series, which is consciousness and reality. And I don't intend a pun here, by the way. But what, according to you, is really consciousness? Because I know you, from a clinical perspective, you've been doing all this research on the brain, but ultimately, if you look at the larger picture, what exactly is consciousness and what exactly is reality? Because you did mention at some places about out-of-body experiences and just this not the very usual means of perceptions, right? So are there like other kinds of perceptual abilities and also alternate realities, perhaps? So again, what according to you is consciousness and what is reality?
Well, I think it's clear from a neurological perspective that we all look at the world from our own angle, creating our reality. So we were, I don't know, 100 people participating to the lecture. The experience was different for each and every one of them, even if objectively, there was this video and these slides. So this is very important and very true. I think we are very much struggling with the scientific method. I definitely believe in, and that worked so well to understand the origin of matter and the power of physics and chemistry. But even quantum physics, with all its complexities, doesn't tell us anything about what is life and what is consciousness and my subjective experience. So your question, Kunal, is definitely very, very challenging. So we can agree that there's some objective reality out there that we can capture with the mathematics and the different hard sciences. But how I would perceive that as a living animal, human, is of course very different, and the brain plays a big role, but kind of is there to permit me through my senses to perceive this, to make sense of it, to increase my chances of survival, to also permit me to have subjective experience that are stimulus independent, to create my internal reality. And I think we're just struggling to define these concepts and the different layers of what we call consciousness, and that leads to a lot of discussion and disagreement. But at least I think we should try, and I'm naively optimistic that we can make progress, and it's too important not to do it. And for way too long, I believe we considered it too complicated. And there was the time of Freud and Jung and William James, and then there were the behaviorists saying, well, this is too complicated, we just look what's going in, what's going on. And that has really damaged our field, I think.
Thank you. I would like to start with a kind of provocative question, or kind of a different question. Actually, I like this one from one of the participants, is that we are assuming that consciousness has its locus within the brain. And I know this talk was focused on the brain today, but what is the evidence that consciousness itself is strongly connected with the brain, as in these individuals, the heart is also working, and in some Eastern thoughts, there is evidence, or it gives sort of the ideas that consciousness is located in the heart, and the intelligence in the brain, or this discriminative or sensory capacity in the brain. So have you really thought about this aspect of people keep saying heart-brain connection, and just monitoring the rest of the neural system? What happened to that? Right.
Yes, of course. I'm a neurologist, so my favorite organ is the brain. And what I see every day is, of course, if you damage that brain, you change your perceptions, thoughts, and emotions. I think we can all agree on that. And if I change it chemically, it will have an impact, or metabolically. There's no question about that. Should we only look at the brain? Of course not. This brain is part of me as a living animal interacting with others, and that is tremendously important. And there is, and we've published on the interaction between the heart and the brain. So that is fascinating, as the interaction between the gut and called the second brain and my billions of neurons up there. However, I do think the brain deserves its place as the candidate of what seems to be necessary and we think sufficient, without having the arrogance that we understand consciousness and hence need to keep an open mind. But one then also needs to turn the question around. What is the evidence that you can have subjectivity, thoughts, perceptions, emotions independent of your brain? And so far, that evidence has not been convincing. And I think, well, if you talk about the heart, fully agree that it's important. And of course, there's this more, I would say, poetic interpretation of, I'm more than a rational being. I'm also having emotions, and there is my heart, and can we ever explain love, and so on and so forth. And emotions are, as Damasio says, it's an experience in my whole body. My heart rate goes up, and it's not to be reduced to some brain area or neurochemical neurotransmitter. But for example, take the first heart transplantation. South Africa, 1969, it was a shock to many people. Well, these people didn't fundamentally change. If I would transplant your brain, that would be very different. And still, this is technically not possible. We see through the study of organ transplantation that we can now replace many organs without fundamentally changing who you are. But the brain there, again, holds quite a special place. And I think that's quite illustrative, without, again, diminishing in any way the importance to look at a more holistic way in how the different organs interact, and also how consciousness is a social construct, and that it's there for us to interact as a social species.
Thank you. Just maybe a couple more questions. Here's one from Jay McClelland, who I believe is from Stanford, who asks, how do you think about whether out-of-body experiences are real? And I'm going to add to that question. You mentioned about NDEs, and generally in the context of extraordinary perceptual abilities, there is this notion of two different networks in the brain that are active during this kind of perceptions. So we would like to hear some more on that from you, if possible.
So in our series, about 80% of people with a near-death experience have these out-of-body experiences. And again, without being, too reductionistic, I think it's interesting to note that, for example, stimulation of the right temporal parietal junction area, as has been published by Dirk de Ridder, so that's very interesting. It's not the full blown. And then there's the question, well, what does it mean? A bit similar to what does it mean to dream, right? I'm putting up the lab in Canada. We're now taking a broader view on also meditation. And I think there's not just the Buddhist and Hindu tradition. This is universal and of all time. So working with the First Nation, American, Indians, the Autochtons, the Inuits, they have their traditions. And if they have a dream that they were bitten by a snake, the next day they would, treat for this. And of course, it's not my role as a physician or as a scientist to say what this means to the person. This is the field of religion, of your personal philosophical belief system. So the real question is whether these near-death experiences, I think, are proof that there can be subjectivity independent of the brain, and that there is some non-local, call it cosmic or whatever consciousness. And experiments have been done also where people in the AWARE experiment, for example, that has been published, hide objects above, close to the ceiling. You can't see it from the perspective of you laying in the bed. And that in places where cardiac arrest and NDEs can occur. And so far, we haven't a single of these patients who were able to tell us in the controlled conditions. I think that's very interesting. I think we should continue that because, of course, this is changing all our understanding and the physics and biology of what we think to understand in medicine. So I think we should just increase our efforts to study these phenomena, despite the fact that they're notoriously difficult, even more so, of course, than dreams that you can reproduce, and that we still don't understand why we have the dreams we have. And for NDEs, it's even more challenging. So we're just going there step by step. And I think we need to do that with an open mind. It would be dogmatic to say, no, it must be in the brain. But still, of course, sticking to the scientific method, which is, I'm challenging what I think to understand with what I think I measure. And I'm very happy to collaborate and to work together on these very, very challenging fields. And out-of-bodies are interesting also because we're talking about something not many of us have experienced. I think, Kunal, there's a difference between knowledge, and you're a physicist. You're a very, very intelligent, rational being, and there's all these experiments and the theories we have. And then there is just the raw, pure experience, right? If you meditate, if you have a dream. And that to me is increasingly clear that there's both of these, and that I think we need to invest on both in able to for us to walk.
Thanks again. Maybe we'll end with this one quick question, which is basically two parts. Artificial intelligence, right? It's becoming more and more important, and you mentioned towards the end of your talk. So this question is, how can we be certain that highly complex AI systems are not conscious? And maybe just a parallel to this, I would say finding life in the universe is becoming increasingly practical now, with so many different experiments planned for like other planets and SETI and things like that. So what could be the tracers of conscious life, you feel?
I will start with the second one. I'm not an expert. We have, of course, these exoplanets, and the challenge again to define life, because we look at this from our limited point of view of life on this blue planet. And again, I think that without speaking in name of the astrophysicist, that it's probable that there's life out there, statistically speaking. And again, then the challenge is, what do we truly mean by life? And it comes down to the definition. Then whether the machines and the supercomputers are conscious, I said, I don't think so. I think there's more consciousness in a fruit fly. And they can just pretend to have a thought, also read our emotions and have some kind of pseudo empathy, but we shouldn't be fooled by that. I think the real challenge to me is to think about animal well-being and how we treat them and what we do know about their capacity for consciousness and cognition. I wouldn't care too much if I'm talking to you now through my MacBook. I can slam it against the wall and don't feel bad. I wouldn't do that with my dog. But you're true. This is kind of an intuition, right? As long as I have no explanatory theory of consciousness, it comes down to this clinician dealing with patients who, if you tell me you have a headache, I'm going to believe you. That's how we work. But you could be a zombie. All of this could be just pretending that there is subjectivity in there, and it's very, very hard for me to prove, that you are experiencing anything. And there's the philosophical zombie experiment. But I do think, for me, that there is matter organizing into living systems, and that in there, through evolution, consciousness emerged. And I don't see that in the artifacts we created in supercomputers. They're very, very useful. They help us. We will need to make good use of them. But they will not help us in solve the big questions about what is good or bad. I mean, that's our again, raw feeling and challenge.
Thank you very much, Stephen. It's been a pleasure and honor having you. And just maybe a final remark before we end is this was our final colloquium of this current academic year, and we will reconvene again during the next academic year around October. So stay tuned for more details on the next set of colloquia in the next series. In closing, I would like to thank again our esteemed speaker, Stephen Laureys, our co-host, Martin Fleming, all the organizers from Caltech, Stanford, and MIT and IMIX, and all the participants who made this event possible. So thank you very much and have a great day.